All right. So as I was mentioning before, also, sorry, let me pull up the participants window. So just in case anybody wants to ask questions, or if we have any latecomers here, I can see what you guys are saying or are curious about. So here is a micrograph of cardiac muscle, right? So it's super, super similar to skeletal muscle, right? Like it looks almost identical, but some of the differences are notably the nuclei that are present in cardiac muscles. So cardiac muscles tend to only have one to sometimes like up to 5 nuclei in a given muscle cell. They're not like skeletal muscle fibers that'll have hundreds of nuclei in them, right? So what's also interesting too is that the striated patterns are still present here. So we've still got those actin and myosin filaments. We have the cross-bridge cycle. We have calcium signaling, tropin and tropomyosin. We still have all of that stuff that's at play here. So on a functional level, cardiac muscle produces force in the same way that skeletal muscle does, and really the same way that smooth muscle does. Smooth muscle just doesn't have as much actin and myosin in it. But one of the differences here is that we have these large intercalated discs, right? So they kind of act almost like gap junctions between cells. But these structures are essentially what act as a buffer system for conducting electrical potentials between cells. Okay. All right. Thanks, L'Oreal, for letting me know. I appreciate it. Okay. So those intercalated discs are really cool. Like I said, they act as that buffer system to prevent the heart muscle cells from experiencing kind of like power surges, right? So in a practical sense, let's kind of look at what that means for force production for the muscle cell, right? So as we know from way back in chapter 8, we understand that muscles respond to electricity via, contractions, right? So they produce a twitch response. And we know that if we can stimulate a muscle with, different frequencies of electrical impulses, then we can, add multiple twitch responses, right? So for example, on the left-hand side of this figure here, we have our skeletal muscle action potential on the top, and then we have our skeletal muscle force production as a response to that particular action potential, right? So, remember our action potential is literally just our electrical impulse. That's essentially we flick our switch on and then we flick it off immediately to represent like a single signal output, right? So we've got our depolarization phase, sodium channels open, potassium channels begin to open, and then we've got the repolarization phase, right? So all of that stuff we remember from our action potentials, okay? So what's interesting with skeletal muscle force production or tension production here is with this twitch contraction, maximum tension is obtained after the refractory period. So if we line this up, so both of these graphs are representing the same exact amount of time that's passing from when the nervous system is sending the electrical impulse to the muscle and then the ultimate response to the muscle. So the force production comes later, pretty much after the refractory period. So after the neuron has completely reset, that's when the muscle is like finally getting the signal and saying, okay, cool, we can, start producing force here. So maximum tension is produced after the refractory period, right? In that purple shaded area. So see our tension develop here, whereas the refractory period is occurring just here, all right? So this allows for increased tension with additional stimulation, right? So this goes back into that idea of temporal summation, where we understand that if we increase the frequency at which we stimulate our skeletal muscles, then we can produce greater and greater force, right? So that's the cool thing. The other interesting component to that too is with increased frequency of stimulation, then we also increase what we call motor fiber recruitment. So more muscle fibers are going to then start being stimulated and contracting, right? As we increase frequency, we add more neurons to this, then more muscle fibers begin to start contracting. But ultimately, what ends up happening is there's an issue with frequency of stimulation and then skeletal contractions, right? So what will eventually end up happening is if you stimulate a muscle to contract at a high enough frequency, let's say, and for humans, for human skeletal muscle, the frequency at which you reach what's called a isometric contraction where the muscle is trying to produce force and it is producing force, but the muscle isn't changing length, right? That frequency is generally around 60 hertz for humans in our skeletal muscles. There's some really cool applications for other vertebrates. Like bears have different frequencies. Hummingbirds have different frequencies as well. So like we all know hummingbirds and how they can beat their wings super, super quickly, upwards of 60 hertz, the frequency which the wings are beating. So the muscles in those wings are contracting at faster frequencies than our skeletal muscles can actually even experience from our nervous system input, which is really fascinating. But anyway, we're not talking about hummingbirds, we're talking about cardiac muscle here. So why is this important? The reason is for a muscle to do what we want it to do, if we're trying to, interact with our environment, if we're walking around and let's say, if you wanted to, go on a run or something like that, your muscles need to be able to contract to produce force. Your calf muscles need to contract so that you can propel yourself forward as you're running, but they also need to be able to relax, right? So a lot of that interplay there between the contraction and relaxation of muscle fibers goes with the synonymous input of our nervous system, right? So the nervous system frequency can't reach that certain threshold because then if the nervous system is constantly stimulating it, let's say at 60 hertz, then the muscles seize up and then they stop contracting. They don't stop contracting, but they stop being able to relax, right? So they stop being able to change length. Now, obviously in our running scenario, like if your muscles, stop working, then you just kind of fall down, right? Like you wouldn't be able to run anymore after that. So that's, probably what would happen with our skeletal muscles. But imagine if that happened to our cardiac muscle. Imagine if the cardiac muscle was, if our nervous system input stimulation reached, greater than 60 hertz, then if our heart muscle stops being able to relax, if the heart muscle is then undergoing an isometric contraction, then the heart muscle is still trying to produce force, but it's not changing length, right? So if the muscle isn't changing length, then we're not pushing blood through our circulatory system, right? So then we go into cardiac arrest, which can happen. But in a normal scenario, we have those intercalated discs that are operating the way that they're supposed to, that again act as that buffer system. So if we look at our action potential for cardiac muscle on the upper right-hand side here, we see that there's this interesting plateau phase as part of the refractory period. So this is the part where we have those intercalated discs coming into play. So as you can see here, what this does is it increases the time at which the refractory period for the neurons innervating the cardiac muscle have to relax. So they take a lot longer, upwards of 500 milliseconds, half a second, as opposed to 200ths of a second, right? Which would be like kind of even less than the normal time it takes for a neuron for our skeletal muscles to relax or to recover through that refractory phase. So neurons innervating cardiac muscle cells take a lot longer to reset, right? So as a result, the tension in our cardiac muscle is produced at almost an equivalent rate of the relaxation or refractory period of the action potential in the nerves that innervate our cardiac muscle fibers. So like I said, what does this mean? It means that under normal circumstances, you can't have temporal summation of nervous system input and force output in cardiac muscles. What that means is that we can go on a run and we can increase our heart rate and we can increase our nervous system input to the heart, but the heart won't undergo an isometric contraction. Again, under normal circumstances, it won't undergo cardiac arrest because of this cool nervous system interplay, because their action potentials are fundamentally different compared to skeletal muscle action potentials. So that's kind of a heavy, like, physiological topic, but it's a really cool difference between skeletal muscle and cardiac muscle, is this plateau phase that extends the refractory period of the nervous system input for cardiac muscle. So it allows for tension to develop at the same rate and for the muscle to actually relax at the same rate as the nervous system does. So no temporal summation means that we can increase heart rate under normal circumstances without undergoing cardiac arrest, right? So really cool stuff. Okay, so I kind of have some of those isolated and blown up a little bit so we can see this a little bit better. Again, we've all seen an action potential for our skeletal muscles, so we don't really need to see this. But again, kind of recognizing that this blue shaded part represents the refractory period, for our nervous system input for skeletal muscle. So then we see that tension has a lag period. So tension development has a little bit of a lag period. So the neuron here is pretty much completely relaxed. And so then what we can do is stimulate that muscle again. And if we increase the frequency, then we can increase force output until we ultimately reach isometric contraction. However, that's not the case with cardiac muscle because of this plateau phase. We extend the time that it takes for that muscle or for that neuron to actually be able to reset and repolarize, right? And then again, kind of comparing the force production in cardiac muscle here, we can see that there's almost perfect overlap between the refractory period of the neurons that innervate cardiac muscle and then the tension development that occurs in our cardiac muscle versus the refractory period in the skeletal muscle neurons and then the tension development as it corresponds to that, right? So really cool stuff. So again, looking at those neurons in question, these ones are specifically called Purkinje fibers, okay? So in general, the way that our nervous system introduces electrical impulses into the heart is pretty much everything synapses with the sinoatrial node, right? AKA the pacemaker. So the sinoatrial node has a few different nerve fibers that can then attach to what we call the atrioventricular node. We also have some nerve fibers that extend back and then attach to the left atrium as well, right? So active potentials pass through the atrioventricular node and then along the atrioventricular bundle, which would be just here, kind of running right along the middle of the heart via the cardiac septum, right? So it extends through the fibrous skeleton into that interventricular septum. The AV bundle divides into left and right bundle branches, that'd be down here, okay? And active potentials descend to the apex of each ventricle along the bundle branches. These are then carried by the Purkinje fibers from the muscle branches into the ventricular walls, where we then have the same exact idea behind calcium signaling, troponin, tropomyosin activation, cross-bridge cycling, all that same stuff, right? Except the difference between our cardiac muscle and our skeletal muscle is that there's no breaks. There's no relaxation phase, right? So these, I mean, there is a relaxation phase, but there's no like complete cessation of muscle activity, right? These our cardiac muscles are always moving, always activated. Okay, so now we're going to move on to one of our most important diagnostic tools clinically for evaluating what the heart's doing, right? So this diagram represents something called an EKG, an electrocardiogram. But some of you probably recognize that last time you checked, cardio wasn't spelled with a K, right? So why the heck is it spelled as EKG instead of ECG? Well, the truth of the matter is, there's some clinicians who still do or will write out orders for EKGs as ECGs, right? And it's a lot easier to distinguish, nowadays with technology and being able to write, digital reports for lab orders and things like that. But it started out initially because there's, obviously, as we know, another diagnostic tool known as an EEG, an electroencephalogram. So when we looked at the brain waves that we had discussed way back in chapter 9, I believe, when we talked about the central nervous system, we saw an EEG and we saw, how we evaluate and measure brain waves. So there was some common, mix-ups between, the C and the E for an electrocardiogram versus an electroencephalogram. So some people, most of the time, will, write out just EKG, but it means the exact same thing. So if you see one or the other, EKG and ECG, they're essentially the same thing. All right. So what the heck is this thing doing? What are we looking at here? An EKG is just that. It's an electrocardiogram. It is a measurement of the electrical activity that the heart is producing, right? So what we can do is we can represent the activity of certain parts of the heart in this sinusoidal weird kind of waveform right here, right? So each of these little moments of depolarization and repolarization mean something. And for the sake of completion, just to kind of recognize and so that you understand, these are actually inverted. So the depolarization values are actually negative because the electrochemical gradients in the heart create negative ion concentration. So there's net negative charges. But for the sake of understanding and interpreting it a little bit more logically, it's actually flipped when it's represented on an EKG right here. So the millivolts are actually inverted for that reason. It's not something that you'll have to remember for a test or anything in here, but just in case any of you guys are interested in going into nursing, whether it's your BSN, LVN, whatever, and you have to interpret EKGs, now you know kind of what's going on here. But like I said, this is a diagnostic tool that helps us understand the electrical activity of the heart. It's important to recognize that the EKG does not actually tell us exactly what the heart is doing in terms of physical activity. We don't know exactly if the ventricles are pumping. We don't know if the atria are pumping. We don't know any of that. What we see here is the electrical activity that are representative of each of those areas. And then obviously if a person is conscious, or if we can observe the heart actually beating, then we know that each of these areas of the heart are actually behaving the way that they're supposed to. But you can have electrical stimulus and electrical input, but the heart can actually not be doing anything, right, under cardiac arrest, right? So that's an important distinction here, is as you're reading an EKG, the patient's heart may not be doing what the EKG says it is. This is just a representation of the electrical activity here, all right? So again, kind of weird, circumstances aside, how the heck do we interpret this? What does this mean? Well, so we've got a couple different regions that we're going to look at here. So we've got this little green hump called the P wave. We have this middle section with this massive depolarizing spike here called the QRS complex. And then we've got a final T wave out here, all right? So the P wave represents what we call atrial depolarization. Now, you can also think of the words depolarization and repolarization as contraction and relaxation. Okay, so I'll put that in the chat here. I think I have it listed up here as well. It pretty much means the same thing. But again, for continuity's sake here, I'll try and make sure that I stick with depolarization, repolarization, but I might accidentally say contraction. But they mean the same thing. And again, we're using depolarization and repolarization because this represents electrical activity. So depolarization is contraction of that particular chamber. And then repolarization is relaxation. So they essentially mean the same thing. So the P wave represents atrial depolarization. So this is where the atria are contracting and forcing blood into the ventricles. So they are actively pumping blood into those chambers. We can also use a term like systole. So systolic pressure versus diastolic pressure, if you guys are familiar with blood pressure, right? Systolic pressure is the active force that the heart is exerting against the arterial walls. We can use that same terminology here to represent the active pressure that the chambers are exerting into the next one, or into the next structure or vessel, right? So P wave represents atrial systole or atrial depolarization. So these are actively forcing blood into the ventricles. Then we get to the QRS complex here. And so this one actually tells us a little bit of two different things that are going on. This is representing the atria repolarizing, but also the ventricles depolarizing, right? So two different things are happening in the QRS complex here. So we have atrial repolarization and then ventricular depolarization, all right? So atrial diastole and then ventricular systole. So diastole meaning passive pressure, Okay. So then we've got finally our T wave, which represents our ventricular diastole, or the ventricle repolarizing and resetting. All right. So that's what each of these different regions of the EKG are referencing. And then the PQ interval represents the total range at which the atria are depolarizing and repolarizing. And then the QT interval represents the entire range at which the ventricle depolarizes and repolarizes. Right. So it's pretty straightforward. Okay. So yeah, this is an EKG. Now, there's if you've ever had an EKG done before, depending on what kind you have done, there's a couple different kinds that you can do. Normally in a lab setting, we would give you kind of like a very simple one where we do a 3-lead EKG, which we essentially repeat this graph 3 different times. So we measure from 3 different electrodes that are placed on the chest in strategic positions. But there's also a more thorough one that you can do called a 6-lead EKG, where you also use leads that are attached to arteries in the ankles as well. Right. So 3-lead and 6-lead EKGs, they'll again paint a lot of the same story, but the 6-lead EKGs can actually pick up more minute arrhythmias or drops in pressure in the heart, or drops in blood pressure I shouldn't say in the heart, but also in the arteries that are part of the circulatory system too. So 6-lead EKG gives us a little bit more definition there. All right. So on the topic of different arrhythmias, we have a bunch of different kinds of abnormal heartbeats, right? So some of the more common ones that we're probably familiar with are tachycardia and bradycardia, right? So tachycardia, where you have an average resting heartbeat typically above 100 BPM. And then bradycardia is a heartbeat that's typically below 60. Bradycardia can be kind of interesting because depending on who is being measured here, usually extreme athletes or athletes who train for endurance capacity will very commonly have heartbeats in the low 50s and sometimes mid 40s. People like Michael Phelps had heart rates in the low 40s, and I think like his lowest resting heart rate was in like the high 30s or something like that, something like obscenely low. So things like cardiovascular health can also, drop this below 60 BPM. Okay. All right. Thanks, Alexis. We might actually be done by then, but I mean, so since you're doing that, well, good luck. Okay. So bradycardia below 60 BPM, tachycardia above 100 BPM. All right. Then we have sinus arrhythmia, where the heart rate can vary as much as 5% during the respiratory cycle and up to 30% during deep respiration. So depending on what your respiratory input and output are, that can also affect your cardiac output in your rhythm. Then we have paroxysmal and atrial tachycardia, sudden increase in heart rate to 150 to 250 BPM for a few seconds or even for several hours. So what this will look like on an EKG is the P waves precede every QRS complex, and the P wave gets inverted and superimposed on the T wave. So essentially what's happening here is the atria are kind of preloading the ventricles. So excessive sympathetic stimulation, abnormally elevated permeability of cardiac muscle to calcium ions, right? So too much calcium increasing the stimulation of that of the heart rate can cause this weird random excessive tachycardia, right? Then we have atrial flutter, as many as 300 P waves per minute, right? So, kind of spastic atrial depolarization and repolarization, and 125 QRS complexes per minute, resulting in 2 or 3 P waves for every QRS complex, right? So you could have like several different P waves that are preceding that QRS complex, right? So the atria flutters. And then we have atrial fibrillation, where we don't have any P waves, so the atria are not depolarizing. We have normal QRS and T waves, and there's irregular timing, okay? So ventricles are constantly stimulated by the atria, and then we have reduced ventricular filling, increasing chance of fibrillation, right? So again, ectopic beats in the atria. And then ventricular tachycardia frequently causes fibrillation, often associated with damage to the atrioventricular node or ventricular muscle, right? So overactive ventricles. So you would probably have, I haven't really looked into this too much, but you might even have variations in the QRS complex. You might even have um, several different QR parts of the QRS complex that might precede one another as well. Oh, before I forget, I don't know if any of you guys looked up the tombstoning effect that I had mentioned last Tuesday as well. So tombstoning is something that can present on the EKG as an over accentuated T wave. So essentially, let me see what I can do here. So I can draw on this. So what will happen with the T wave is the T wave will essentially bulge outward like this and look like a giant tombstone. So this tombstoning effect is indicative of myocardial infarction and blockage, usually of that left anterior descending artery that we had talked about last time. So if you see that on an EKG, that's usually what's going on there, or there's some issue with ventricular filling. It could be hypertension episode or hypertensive episode as well. Some people who have, different kinds of arrhythmias can develop hypertensive episodes, especially if they have abnormal salt content in their diet. And so usually one of the quickest ways to kind of solve something like that is with diuretics. But yeah, that can happen sometimes. So yeah, that tombstoning effect, right, can be indicative of that left anterior descending artery. All right. So let's take a look at the cardiac cycle here. Okay, so kind of referring back to our EKG, and what we'll actually do is we're going to take a look here at this big graph. If you guys want to follow along in the textbook as we kind of go through this, this is a really great figure that kind of shows you what's happening in the heart as the EKG is occurring. But we'll take a look at the cardiac cycle and what's going on inside of the heart first, and then we'll look at that and pair that up here. Excuse me. So number one, the atrium ventricles are relaxed, the atrioventricular valves are open, and blood flows into the ventricles, and the ventricles fill to approximately 70% of their volume. So this is kind of a little bit where we have essentially what's called ventricular preloading. There was some interesting, or obviously, brilliant cardiovascular physiologists in the early, not early 90s, but kind of in the mid 1900s. But they generated something called Starling's law, which essentially represents, you can apply it to most muscle, but they use it a lot for cardiac muscle output, where basically if you preload and you stretch the muscle, the magnitude at which you preload it is going to be directly correlated to what the output or what the force production of that muscle is. So basically, what does that mean for cardiac output? It means the more that you preload the ventricles, then the greater the ventricular output is going to be, right? So number one, we've got 70% volume filling of the ventricles here. Our atrioventricular valves are open, right? So our atria are kind of passively filling that up, right? And then for that last 30%, that's where we have our atrial depolarization. So that would be our single P wave that we had just talked about. So the atria contract and then complete that ventricular filling up to 100%, right? Number three, contraction of the ventricles will then cause pressure in the ventricles to decrease, and almost immediately the atrioventricular valves close. So this is our first heart sound, right? So if you ever use like a stethoscope or something, you've got that lub dub, lub dub, lub dub, lub dub. So that first sound that we hear, the lub sound, is the atrioventricular valves closing due to the pressure buildup in the ventricles, right? So the pressure in the ventricles will continue to decrease until ultimately the sinoatrial, the semilunar valves fail and then allow for blood to be deposited into the arteries, right? So continued ventricular contraction causes the pressure in the ventricles to exceed the pressure in the pulmonary trunk and the aorta. As a result, the semilunar valves are forced open and blood gets ejected into the pulmonary trunk and the aorta. And then at the beginning of the ventricular diastole, the ventricles relax and the semilunar valves close, which is that second heart sound, right? So at the beginning of that ventricular diastole, they relax, okay? And then they continue to relax and allow for the atria to open up, and passive filling of the ventricles continues, right, up to that 70% volumetric threshold. And then the cycle continues, right? So there's a couple big points here that we want to kind of make sure that we recognize. So we've got at steps 3 and 5, we can figure out where we've got our two different heart sounds that are occurring. So really a lot of it has to do with pressure buildup or pressure release in the ventricles. So as pressure is continuing to build up, they close the atrioventricular valves. That's that lub sound. And then as the ventricles build up enough pressure to eject blood into the arteries, they'll produce enough force until the pressure gradient is greater in the arteries than it is inside of the ventricles. And then the semilunar valves will close, representing that dub sound, right? So that's our second heart sound. All right. So in terms of the cardiac cycle, it's not really rocket science here, right? We've got filling of chambers, we've got muscles contracting, a closing of chambers, pushing blood out into the vessels. That's not anything that's like, that should be kind of crazy new information to us. But what's kind of interesting too is we can map up what's happening inside of the heart with respect to the cardiac cycle in a couple of different ways. We can match it up with what's going on our EKG, which is usually one of the more common ways to use that diagnostic tool. But we can also evaluate it compared to things like pressure buildup inside of different chambers in the heart, and then volume of the left ventricle and how that changes. And really, we kind of care about the left ventricle here because it's going to be sending blood out to the entire body, right? So understanding how the volume of that ventricle changes with respect to something like the EKG or even heart sounds is kind of cool, right? So we can see that, just kind of looking at our bottom two figures here, the left ventricular volume, we can see that, as our atria has, completed its diastole here, so we've actively filled the volume of the ventricle here, so we kind of peak that right here. Then the ventricle contracts, right? So we've got our first heart sound that's occurring right during our period of isovolumetric contraction, and then the ventricles produce enough force to force blood out into the atria, or I'm sorry, not into the atria, into the arteries. That would be bad if it was going back into the atria. But then we can see that volume drops here as our ventricles begin to kind of recover from that cardiac output. And then we can see that as the pressure gradient drops right here, and we'll look at pressure here in just a minute, then we can see that we have our second heart sound. So it's the closing of the semilunar valves, and then ultimately the passive filling of our ventricles again. So it's kind of cool to kind of compare that to, what's going on in the heart. But yeah, let's take a look at what's going on in terms of pressure gradients and pressure development, right? So we have the pressure change of the left atrium in our blue dashed line right here, and then the left ventricle in the black line, and then the aorta, right? So our red dashed line right here. So we can see that the pressure gradient develops right here. Let's see, we get Tony in here. But then as all of this is occurring, so the atrioventricular valves, those close, and then it makes sense that we have a small pressure drop as the ventricles are going to be continuing to develop pressure because we're closing off those valves and isolating them from the ventricles, right? So the ventricles are going to continue to develop pressure until that pressure exceeds that of the aorta right here. So once the pressure of the ventricle gets to be greater than the aorta, then the ventricle or that semilunar valve opens up, and then we see that obviously both pressures will increase up to a certain threshold, right? So once that threshold gets to what we would determine our, peak systolic pressure, right? So when you guys measure your blood pressure, that's what we're measuring. We end up having that ventricle relax, and again, a lot of that is determined based on nervous system input and how much force the ventricles are able to produce. But eventually, those muscles are going to fatigue; they're going to relax, right? So then the pressure begins to drop. Semilunar valves close. Second heartbeat sound appears here, and then the pressure continues to drop because then the ventricles are going to relax until they ultimately become completely relaxed at the beginning of our T wave again, right? So we have our AV valves that open up and then allow for passive filling of the ventricle again. And then the cycle continues. So it's kind of cool. All right. Any questions about this figure so far? You guys can give me a thumbs up if you guys are good, or if you have any questions, you can let me know here. Thanks, Riley, Chris, Dane, John, Kevin. Awesome. Okay, cool. I'm trying to think if there's any other fun facts about this. Nothing's coming to mind, but I'm sure that'll obviously, I'm sure I'll remember that once we're done with class today. So here we've got a couple of different points where in pink we can see these are some of the more common spots to place a stethoscope to evaluate the sounds of each of the valves, right? So each of these pink circles are spots where kind of general practitioners or cardiologists will place a stethoscope to evaluate whether or not the valves in our heart are closing and opening properly. Because as we talked about earlier, again on Tuesday, one of the more common valves that will end up failing is usually the bicuspid valve, right? So on the left side of the heart, this valve will tend to kind of fail or wear out over time. So it's not uncommon for people usually past the sixth decade of life to develop something called a heart murmur, where this bicuspid valve can start to weaken, and then we can end up having a little bit of blood backflow into the left atrium. And it's something that needs to be monitored and taken care of if it becomes too advanced, because then that can lead to hypertension, sometimes depending on the valve, usually not the bicuspid, but if you have a leaky tricuspid valve, you can develop pulmonary hypertension, which is really bad. But then you can, if the bicuspid valve gets leaky, you can develop systemic hypertension, where the left ventricle is kind of working a lot harder than it's supposed to, and cardiac output changes and isn't working appropriately. So a couple different homeostatic mechanisms on ways that we can modulate the heartbeat and then essentially affect something like cardiac output are things like blood pressure and then chemical balance in the bloodstream too. So obviously if blood pressure goes up, we have these cool little baroreceptors that sit right in the aortic arch that can respond to and sense changes in the blood pressure, right? So what things can cause drops in blood pressure? Things like systemic shock, cardiovascular shock, anaphylactic shock. Most kinds of shock will cause the body to, or will cause a change in blood pressure that can be a response, or that can be picked up by these baroreceptors. So if something like blood pressure increases, right? So let's maybe say we've got vasoconstriction, we've got adrenaline, whatever kind of a stimulus might cause blood pressure to increase. Cardioregulatory centers in the medulla oblongata will decrease sympathetic stimulation of the heart and adrenal medulla, and increases parasympathetic stimulation of the heart. So remember, sympathetic being our fight or flight, parasympathetic being rest and digest, right? So if we get too far beyond that norm, then we can increase parasympathetic activation. We end up releasing hormones like acetylcholine into the heart muscle, which, as you guys remember, acetylcholine was the neurotransmitter that caused an excitatory response in skeletal muscle. But remember, in cardiac muscle, it actually has the opposite effect. It causes a decrease in the activity of cardiac muscle. So cardiac output will go down. And I keep saying cardiac output. I should probably define that. Cardiac output is stroke volume times heart rate, okay? So things that affect the rhythm of our heart and how fast it's beating, and also how much volume of blood the ventricles are putting out, all combine to affect something called cardiac output, okay? So changes in cardiac output typically are not good, especially if they're sustained, right? So it's important that we maintain this homeostatic control over cardiac output, where we can modulate things like stroke volume and heart rate to affect our cardiac output. So what's kind of interesting, I mean, it's a math problem. You can play around with values here. So, people like athletes, or if any of you guys train, endurance training or anything like that, what you end up doing is you increase the size of your heart. So your stroke volume will increase. And as a result, your heart doesn't need to beat as fast in order to pump as much blood as it needs out to the rest of our body, right? So, something like increasing stroke volume can have a corresponding decrease in heart rate. Conversely, if you have poor cardiovascular health, then your stroke volume will not be as high, and then sometimes your heart rate can increase through to not only compensate for that, but also for other health reasons. But also, if we compare heart rates of children or of fetuses, right? If any of you guys have had kids before, when you go to ultrasounds and you have the kind of like your body scan, kind of 10-week appointment right around there, the heart rate of a developing fetus is right around 150 beats per minute, right? And that's normal. That's good for a developing fetus, right? So the size of the heart will actually inform things like cardiac output. So obviously, if you have a small heart, small stroke volume, and then in order to have efficient cardiac output, you've got to have a faster heart rate. It's the same reason why things like scaling coefficients between like elephant hearts versus mouse hearts, it works this way, right? Stroke volume is going to be much greater in something like an elephant, so heart rate is going to be fairly low. Stroke volume is going to be fairly small in something like a mouse, so heart rate is going to be quite high. Again, mice tend to be, kind of hovering right around like 160, 170 BPM for their average resting heart rate. So, yeah, size coefficients, scaling, really kind of interesting things that can affect cardiac output. And then here's that Starling's law that I was mentioning as well. So, what we can do to kind of modulate the cardiac output in another way is by determining how much we stretch the wall of the ventricle. So if we preload the heart more, then we can affect cardiac output because we're going to be changing the volume of the ventricle even more. So the stroke volume will increase as a result, right? So Starling's law is kind of cool because it's a somewhat, what's the word? It's a somewhat malleable, I don't really like using that word. It can change. The Starling's law can change. It's this idea that represents how flexible cardiac muscle is. So as I mentioned, we have pressure receptors that exist within our arteries, our major arteries of the heart, but we also have chemoreceptors as well that'll respond to changes in things like blood pH. So we've already talked about a couple instances where blood pH and the effect of pH on different enzymes in our blood can obviously have adverse consequences for things like that, but it can also change things like cardiac output too. So if blood pH increases, chemoreceptors in the medulla oblongata detect an increase in blood pH, often caused by decreases in blood carbon dioxide content. Control centers in the brain will decrease stimulation of the heart and adrenal medulla. The sinoatrial node and cardiac muscle decrease activity and heart rate, and stroke volume will decrease, right? So heart rate and stroke volume go down, cardiac output goes down. So if we're like hyperventilating or something like that, then this will typically be like a side effect of that. So we want to decrease our cardiac output so that we can restore our blood pH. So you might be thinking, well, okay, how the heck might cardiac output affect something like blood pH? It's linked to the pulmonary cycle and some of the enzymatic reactions that occur in our pulmonary or in our respiratory system. So we'll talk about that once we get to the respiratory chapter, which I believe is either chapter 14 or 15. So that's coming up. And so we'll circle back around to this and see really kind of how we can change our blood chemistry, our blood pH, just by things like affecting our breathing pattern. It's kind of cool. So then we can have the opposite happen where if blood pressure drops, if it becomes too acidic, chemoreceptors in the medulla oblongata detect a decrease in blood pH, often caused by increases in blood CO2. Control centers in the brain increase stimulation of the heart and adrenal medulla. Sinoatrial node and cardiac muscle increase activity, and heart rate and stroke volume will increase, increasing blood flow to the lungs, right? So the lungs are kind of the main site at which we can control things like blood chemistry. Pretty neat stuff. All right, so then here we've got a kind of a big flow chart talking about each of those different components that we discussed with baroreceptors, chemoreceptors, how the parasympathetic nervous system can affect cardiac output, sympathetic nervous system can affect it, as well as different kinds of hormones. Things like adrenaline and noradrenaline can affect cardiac output. So all of them have feedback mechanisms that usually will relate back to the medulla oblongata, right? So that part of that lower part of our brain stem, we've got a lot of different neurons synapsing, and we control a lot of our autonomic responses of organs like our heart, right? So here's some of the locations of those baroreceptors that I mentioned. So we've got some that sit right on the arch of the aorta here, and then we have some that sit up here in our common carotid arteries. So really, this is actually the internal carotid artery. But yes, we've got one right at the notch here, and then we've got a couple on our right and left sides of each of our carotid arteries, or internal carotid arteries there. So those, again, feed back into the medulla oblongata. Same thing with the ones on the arch of the aorta here. So those can then send signals back to the medulla oblongata, which will then kind of determine whether or not we need to either increase sympathetic stimulation or increase parasympathetic stimulation, and then change the stimulation frequencies of some of those other nerve fibers. And then again, if necessary, if we need to, kind of have what's the word? My brain's not working today. I'm forgetting all of my vocabulary here. If we want to have something work in tandem, that's what I was going for. If we want to have, an in tandem effect here with something like adrenaline, then we can have sympathetic fibers activate the adrenal glands, which can release things like adrenaline and noradrenaline to complement sympathetic stimulation of the heart as well. All right, so some representative diseases of the heart, things like endocarditis, inflammation of the endocardium, affects valves more severely than other areas of the endocardium and can lead to scarring and causing stenosed or incompetent valves. Usually that can lead to things like leaky valves, like I mentioned. Cardiomyopathy, disease of the myocardium of unknown cause or occurring secondarily to other diseases, results in weakened cardiac muscle, causing all chambers of the heart to enlarge and may eventually lead to congestive heart failure. Okay. Rheumatic heart disease results from a streptococcal infection in young people. So Streptococcus pneumoniasin, causing a bacteria that causes strep throat. Toxin produced by the bacteria can cause rheumatic fever. Several weeks after the infection, that can result in rheumatic endocarditis. So inflammation, again, of the endocardium. Reduced blood flow to the cardiac muscle, coronary heart disease, coronary thromboses, right? So we've already kind of talked about some of those. There's some interesting birth defects that can occur as well. So I didn't mention these. I'm glad these are on here so I can remember them. But we can have septal defects where we can have perforations or holes in the septum that separates each of the ventricles. And what that allows for is that allows for mixing of oxygenated and deoxygenated blood. Now, as mammals, that's really not good for us. A lot of our metabolism and our evolution is based around having a separated heart. So we keep our oxygenated and deoxygenated blood completely separate from one another. Our metabolism really depends on that. So if we mix that, then if we get deoxygenated blood circulating within our systemic nervous system, our systemic cardiovascular system, then that affects the metabolism of all the other tissues of our systemic circuits. That's really not good. Then there's this other interesting condition called a patent ductus arteriosus. There's another one called a patent foramen ovale. But if we go back up here to, let me get a better picture of the heart here. Let's see. Oh, this one's got it. So this little guy right here, let me draw this. So this structure right here. Let's see, clear all drawings. That thing right there. That is the ligamentum arteriosum. So it's a little ligament that connects the dorsal aorta to the pulmonary aorta. Now, when we're developing as fetuses, that's actually an open channel called the ductus arteriosus. So if we go back to that list here, oops, I don't want to do that. Clear. well, we have a little arrow on the screen, but the ductus or the ductus arteriosus condition or the patent condition, patent just means open. What that allows for is that allows for, again, another condition of mixing of blood between the systemic and pulmonary circuits, right? So the ductus arteriosus fails to close after birth, so it doesn't transform into the ligamentum arteriosum, allowing blood to form or flow from the aorta to the pulmonary trunk under a higher pressure, which can damage the lungs. Also, the left ventricle must work harder to maintain adequate systemic pressure. So on top of the metabolic issues that come about from mixing oxygenated and deoxygenated blood, we have arteries that are not used to the same pressure that the left ventricle produces compared to the right ventricle. So this can damage those pulmonary arteries as well as lung tissue as well. Okay, so that small ligament here, I'll type that in the chat. Thanks for asking, Pamela. Ligamentum arteriosum. Ligamentum arteriosum. Okay. And then, so just kind of in closing here, yeah, you're welcome. In closing here, we've got a really cool angiogram view of one of the arteries in the heart that's been occluded. And you guessed it, this is the left anterior descending artery, right? So you can see we've got a nice bit of occlusion right here. So we've lost blood flow to every vessel that's beyond this little thrombosis or whatever the clot issue is right here. As we'll find out in our reading from next week's material, there's different ways that we can develop clots. And one of the bigger issues is something called atherosclerosis, where the arteries themselves will harden and shrink because of a buildup of plaque that occurs in between the lumen of the muscle of the vessel and then the endothelial cells that make up the inner lining. It's pretty crummy, actually. So the occluded artery right here, okay? So usually if the artery is occluded like that, if you can't go in and break or remove the clot via an angiogram, then you can insert something like a stent to break down the blockage and then open up that vessel, or you can perform that bypass surgery that we had talked about, right? So with myocardial infarctions, you got to restore blood flow to the cardiac muscle, try and repair some of that or limit some of the damage to the rest of the muscle. Medication to reduce blood clotting. So things like aspirin are typically common of people who've undergone myocardial infarctions, going on a baby aspirin medication, I forget what the term is as like a treatment plan, but basically you get put on baby aspirin for the foreseeable future. You can also be put on tissue plasminogen activators or TPA medication to kind of help increase the breakdown of clots that could occur in the blood. But again, as a trade-off, if you end up getting a cut or something like that, the odds of you dying from loss of blood are much, much higher because your blood isn't going to clot the way that it's normally supposed to, right? So supplemental oxygen, prevention and control of hypertension, angioplasty, or bypass surgery, right? So those are some of the treatment options for heart attacks or myocardial infarctions. All right. So we are done for today. Let me see.